dear students. So today we'll be discussing about a very important topic, that is shoulder joint. This topic is not only important from the point of view of your exams but also in your clinical practice in coming years, because the injuries to shoulder joint as well as the pathologies associated with shoulder joint are very common. So let's start with our topic. So students, at the end of this lecture, you should be able to describe the type of the shoulder joint, what are the different articular surfaces, the ligaments that are acting on it to stabilize the joint, what is the synovial membrane and what are its attachment, the movements that are possible at the shoulder joint, the nerve and the blood supply, that is the neurovascular structures that supply to the shoulder joint. And finally, we'll wind up our lecture with some applied anatomy. Now, coming to this image, here you can see the shoulder joint from the ventral aspect. Now, students, I want all of you to identify few features of this image. Here you can see this is the clavicle. This triangular bone, it is the scapula. This round head with a long shaft, this bone is the humerus. And here you can see the acromion process. So this is the acromion process of spine of scapula. So here you have the acromioclavicular joint. Here you can see this bird beak shaped projection. This beak shaped projection, this is known as the coracoid process. Now, on the shaft of the humerus, you can see beginning from the head, there is some elevation. So, this laterally placed elevation is the greater tubercle, whereas this is the lesser tubercle. And in between these two tubercles, you will find a groove which is known as the bicipital groove. This bicipital groove, it allows the passage for tendon of what? The biceps, long head. The tendon of long head of biceps is going to pass through this groove in between the greater and the lesser tubercles. Here again in this image, you are looking at the shoulder joint from the dorsal aspect. Here you can see clearly the scapula having its spinous process. The spinous process, it is terminating as the flat acromion process. Here you can see the clavicle and here is the acromioclavicular joint. Here you can see the posterior margin of the glenoid cavity. Now, what is this glenoid cavity? We'll see when we'll discuss the articular surface. Here you can see the head of the humerus. And what is this sky blue color structure? This head of the humerus, it is lined by the hyaline cartilage or the articular cartilage. So, all the articulating surfaces in the synovial joints, they are covered by hyaline cartilages. The students, as we see, there are large number of joints apart from the joint between the scapula and the humerus. Now, all these joints together, they are known as the shoulder complex. So, what are the components of the shoulder complex? The first component is the joint between the head of the humerus and the glenoid cavity of the scapula. This is known as the glenohumeral or the shoulder joint. this joint between the clavicle and the sternum. It is known as the sternoclavicular joint. Between the acromion and clavicle, we already discussed, it is the acromioclavicular joint. Now, students, what is this suprahumeral articulation? So, I told you about these two processes of the scapula, that is the acromion process and the coracoid process. This acromion and coracoid process, they are joined by a strong ligament. This is known as the acromioclavicular ligament. This acromioclavicular ligament, the fibers from shoulder joint, they come and blend with this acromioclavicular ligament. This also provides stability to the shoulder joint. So, this is your shoulder complex having the different types of joints. And today we are discussing about this joint, that is the glenohumeral or the shoulder joint. Coming to the articular surfaces. Now here you are seeing the scapula, and this part, it is known as the glenoid cavity. This glenoid cavity, as you can see, it is lined by the hyaline cartilage. Since it is an articular surface, so it is lined by the articular cartilage. Now students, this glenoid cavity, along its margin, it has a thickened rim-like projection. A thickened rim-like projection. This thickened rim-like projection, it is made up of the fibrocartilage. This fibrocartilaginous rim present around the glenoid cavity, it is known as the glenoid labrum. Students, what is the function of this glenoid labrum? Now, as you look at this articular surface, that is the glenoid cavity on the scapula, it is actually very shallow. It is not deep as in your hip joint, where the acetabulum completely encloses the head of the femur. Here in the shoulder joint, what happens is that this glenoid cavity is quite shallow, whereas the other articular surface, that is the head of the humerus, it is globular. So, to increase the depth of this glenoid cavity, there is the presence of this fibrocartilaginous rim, which is known as the glenoid labrum. So, this is another thing which helps in the stability of the shoulder joint. The other articular surface, that is the head of the humerus. So, here this part, this globular part, it is known as the head of the humerus. Students, this head of the humerus, it forms 1/3 of the sphere, and it is also covered by hyaline cartilage. So students, as I told you, the two articulating surfaces, one is the glenoid cavity, which is shallow, and the large globular head. So they don't fit into each other quite properly. Hence, this joint, it is inherently weak joint or unstable joint. But what is the advantage of this unstable joint? It allows for a large degree of movement. So the shoulder joint, it is a inherently unstable joint. However, this inherent instability, it helps in providing the large range of movement that the shoulder joint has. So this inherent instability helps in the large range of movements. What are the different movements that are possible? We will discuss at the end of this lecture. Now students, since this joint is inherently unstable, there are several ligaments which work on it to stabilize the joint. So what are these ligaments? Here is a diagrammatic representation of the shoulder joint. You can see here it is the scapula, then On this side, you can see the head of the humerus. Now, students, the first ligament which I want all of you to look is the joint capsule. This joint capsule, it is a fibrous capsule, connective tissue capsule, which is having fibrous component. This attaches right from the periphery of the glenoid labrum. It attaches right from the periphery of the glenoid labrum and extends onto the head of the humerus. Now, students, in this image where I had shown you the head of the humerus, this junction between the globular part. So, this is the globular part. So, where this globular part is joining with the shaft, here this line demarcates the anatomical neck of the humerus. This is known as the anatomical neck of humerus. So students, this fibrous capsule is going to attach to this anatomical neck of the humerus anterosuperiorly. Whereas inferiorly, you can see it is somewhat lax or loose. Inferiorly, it is lax or loose and it moves downward. So why this laxity is present in the fibrous capsule of the shoulder joint? So that students, when the shoulder joint it is abducted, so there is possibility of movement because of this laxity of the shoulder joint capsule. Apart from that, what are the other important ligaments? Students, we have seen the coracoid process, which was a beak shaped projection. So from the inferior surface of this beak shaped projection, we have a strong fibrous band which moves and blends in with the fibrous capsule superiorly. So this is known as the coracohumeral ligament. Why coracohumeral? Because from the inferior surface or the base of the coracoid process, this ligament extends onto the humerus and it is blending with the capsule of the fibrous capsule of the joint. Now moving to the second group of ligaments. So here you can see three slips of connective tissue fibers, they are running, and these ligaments, they are running from the margin of the glenoid cavity and attaching onto the humerus. Hence these ligaments, these are known as the glenohumeral ligaments. So ligaments running from the glenoid labrum margin to the humerus. So students, these ligaments, they blend in the inner surface of the fibrous capsule. So when we open the fibrous capsule, we can find three thickened strands, which are these: superior, inferior, and the middle glenohumeral ligaments. So you have the three glenohumeral ligaments: the superior glenohumeral, middle glenohumeral, and the inferior glenohumeral. Apart from that, you can see this short fibrous band running from the greater tubercle to the lesser tubercle. So this transverse band, it is generally running over the bicipital groove, because we saw that in between the two tubercles we have the bicipital groove. So this ligament, which encloses the structure which passes within the bicipital groove, the structure we have already discussed, this is the tendon of long head of biceps. So this ligament enclosing the tendon of the long head of the biceps, which passes through the bicipital groove, is known as the transverse humeral ligament. All right. So these are some of the important ligaments. Apart from that, we have another important ligament which is known as the coracoacromial ligament. We'll look for that in the subsequent slides. Okay. So here is a proper image from your atlas, anatomy atlas. So quickly identify here, you can see this is the clavicle, the acromion process, the head of the humerus, and here you have the glenoid cavity margin. So with blue I have drawn the glenoid cavity margin, and with the black I have done the margins of the other bones. So here you can see this entire thing connected from the margins of the glenoid cavity, glenoid labrum onto the anatomical neck in anterior superior region, and finally it is moving down, laxes down, or it is loose as we move inferolaterally or inferoposteriorly. So anterior superiorly it is tightly adherent to the anatomical neck, whereas inferiorly it comes down and reaches to the level which is the surgical neck, the surgical neck of humerus. What is the surgical neck of humerus, students? Why it is important? Now at this level, at the surgical neck of humerus, important structures, that is the axillary artery, the circumflex humeral vessels, these are moving. So these are few ligaments which you could see, and the other ligament which I was talking about, that is the coracoacromial. So here students you can identify this is the coracoid process. This is the coracoid process, and here you have the acromion process. So from the coracoid to the acromion process, you can see these fibers. These fibers running from the coracoid to the acromion process. So these fibers, they form the coracoacromial ligament. This coracoacromial ligament along with the coracoid process and the acromion process, what does it form? It forms the coracoacromial arch. So students, what is the coracoacromial arch? It is the connective tissue fibers, these strong fibers connecting acromion to the coracoid process, and together the coracoid process, this ligament and the acromion process, they form the coracoacromial arch. Now students, this coracoacromial arch, it is also providing the shoulder joint with a greater stability. It acts as a secondary socket. So one socket of the shoulder joint you saw which was present on this side, that was the glenoid cavity lined by the glenoid labrum, with which the head of the humerus is articulating. Now when you look at this coracoacromial arch, it is forming a socket above the head of the humerus, and the suprahumeral articulation that we were talking about, it is taking place between this coracoacromial ligament and the fibrous capsule of the shoulder joint. Students, I hope you understood the concept of the coracoacromial arch. So here again you can see, here you have the greater tubercle, the lesser tubercle, and running in between these two are the fibers of the transverse humeral ligament. What? The transverse humeral ligament. And what they are enclosing? They are enclosing the tendon of the long head of biceps. So this is the long head of biceps. Please pay attention to these images. These images, they show the attachment of the fibrous capsule of the shoulder joint. So as I had told you, anterior superiorly, they are attached to the anatomical neck of the humerus. And as you move down, it is moving towards the surgical neck of the humerus. So here, this is the level of the surgical neck of the humerus. This is a view from the posterior aspect. This view of the posterior aspect, you can see the fibrous capsule, it is posterior inferiorly attached below the anatomical neck and moves down towards the surgical neck of humerus. Okay. So in this image, you are looking at the shoulder joint from the lateral aspect. The humerus has been removed. So what you are seeing in this image is the glenoid cavity. This green colored lining, this is the fibrocartilaginous rim of the labrum, of the glenoid labrum. So here you have the supraglenoid tubercle. Now moving to the next important topic, that is the synovial membrane. Now, students, once we have discussed about the fibrous capsule of the shoulder joint. Now let's discuss what's inside this fibrous capsule. So the inner lining of the fibrous capsule, it consists of the synovial membrane. The synovial membrane, it is attached to all the inner surface of the fibrous capsule. It is attached to the margins of the glenoid labrum. It is also attached to the surgical neck, anatomical neck of the humerus anterosuperiorly and along the surgical neck of the humerus posterior-inferiorly. So it is almost covering the entire inner surface of the fibrous capsule. But one thing we have to note here is that this synovial membrane, it sends out few extensions through openings in the fibrous capsule. So two openings are present, and clearly you have this opening which is uh, allowing the passage of this tendon of the biceps. So surrounding this tendon of biceps, the synovial membrane comes out. So here you can see the biceps tendon surrounded by the synovial membrane. Another extension of the synovial membrane is in between the, we learnt about the superior, middle and the inferior glenohumeral ligaments. So in between the superior and middle, in between the superior and middle glenohumeral ligaments, there is another opening in the fibrous capsule. Through this opening, the synovial membrane comes out to form a bursa, which is known as the subscapularis bursa. Why subscapularis bursa? Because it is in continuity with this space below the subscapularis muscle. We discussed about the different ligaments which are stabilizing the shoulder joint. We also discussed about the synovial membrane which is present within the fibrous capsule. Now, let us discuss about some other structures which help in maintaining the stability of the shoulder joint. During dissection, you must have seen the muscles which is present on the ventral aspect of the scapula. This is known as the subscapularis. Now, as you look at the dorsal aspect of the scapula, here you can see the two muscles, supraspinatus, infraspinatus. These two muscles, they arise from the supraspinous and the infraspinous fossa on the dorsum of the scapula. And the third muscle, this one, which you can see, it arises from the lateral border of the scapula. It is known as the teres minor. Now, these three muscles from the dorsal aspect and the subscapularis from the ventral aspect. Tendons of these four muscles, they blend in with the fibrous capsule. These tendons, they become flat sheet-like structures and they blend in with the fibrous capsule. So as they blend in with the fibrous capsule, what happens? Any contraction of the muscle, it produces rotation of the shoulder joint by varying degrees. Hence, together they are known as the rotator cuff of the shoulder joint. This is very important short note for you students, and also the rotator cuff injuries are very common these days. So here in this image, you can view the shoulder joint from the lateral aspect. The humerus has been removed, and here you can again see the glenoid cavity lined by the hyaline cartilage, and here you can see the cut sections of the muscle. So this is the ventral aspect, and this is the dorsal aspect. From the ventral aspect, you can see this large muscle, the subscapularis. This is its flattened tendon insertion. And superiorly, you have this muscle, the supraspinatus. Posteriorly, you have the infraspinatus and the teres minor. So these muscles, they have been abbreviated as the SITS or the sits muscle. Please don't forget this. The rotator cuff formed by the sits muscle. The supraspinatus, infraspinatus, teres minor, these coming from the dorsal aspect of scapula, and the subscapularis coming from the ventral aspect of the scapula. Already we have discussed about the subscapular bursa, that is the extension of the synovial membrane into the subscapularis muscle tendon, behind the subscapularis muscle tendon. Also, another extension of the synovial membrane we had seen along the tendon of the biceps. Apart from that, there are some other important bursae. For this, I want all of you to look at this image. So, this is a diagrammatic representation of the shoulder joint from the lateral aspect. You are seeing here again the glenoid cavity lined by the glenoid labrum. On the supraglenoid tubercle, you can see the long tendon of the long head of the biceps. Superiorly, here you can identify two bony elements. So here is the acromion, and here you can see the coracoid process. Just below the acromion, you can visualize this blue colored region. It is present below the acromion and above this muscle. This muscle is the supraspinatus. We have just seen in the dorsal aspect, we have the three muscles, that is the supraspinatus superiorly, the infraspinatus posteriorly, and the teres minor. So this bursa, which is present below the acromion, it is known as the subacromial bursa. It is also sometimes called as the subdeltoid bursa. And this bursa, which you can see below the infraspinatus muscle, this is known as the infraspinatus bursa. And anteriorly, I had told you the extension of the bursa from the joint cavity, that is known as the subscapularis bursa. So students, these are few important bursa which are in relation with the shoulder joint. The subacromial bursa, the infraspinatus bursa, and the subscapular bursa. Also, this image we'll see again when we'll learn about the different relations of the shoulder joint. The coracoacromial arch. So this I have already discussed. Here you have the coracoid process, the acromion process, and in between you have the coracoacromial ligament. Now all these three components together, they form the coracoacromial arch, which in turn provides a superior socket. It acts as a secondary socket for the shoulder joint. So coming to this image again, here we'll see the different relations of the shoulder joint. For your idea again, I can tell you this is the, you are looking at the shoulder joint from the lateral aspect with the humerus removed. And here this side is the anterior aspect and this is the posterior aspect. So anything on this side will be the anterior relation, anything on this side will be the posterior relation. Superiorly, you have the acromion process and the coracoid process. together joined by the coracoclavicular ligament. So we had seen in front of the shoulder joint there is a muscle known as the subscapularis. Then on the superior aspect we had the muscle supraspinatus. On posterior aspect we had the infraspinatus and the teres minor. So these four muscles which were forming the components of the rotator cuff, these are the immediate deep relations of the shoulder joint. Ventrally you have the subscapularis, superiorly you have the supraspinatus, and posteriorly you have the infraspinatus and the teres minor. Apart from that, we have also discussed about the bursa lying between the acromion process and the supraspinatus. So this is the subacromial bursa. Then we also discussed about another bursa lying between the below the infraspinatus. So this is the infraspinatus bursa. This extension of the bursa from the joint cavity below the subscapularis is the subscapularis bursa. Apart from that, we know from the acromion process we have the origin of this large muscle, that is the deltoid. Here you can see the fibers of deltoid. In front of the subscapularis, this muscle which you can see, it is the pec major or the pectoralis major. And inferior to the joint, what are the relations? You have the long head of triceps. So inferior relations, you have the long head of triceps and the teres major muscle. And as you know, just below the head of the humerus at the surgical neck, we had the two important structures, that is the axillary nerve and the posterior circumflex humeral artery. So hope you understand these are the different relations. Now if you practice this diagram properly, then in long question of the shoulder joint, you can easily represent the different relations. Whatever you show in this diagram, like anteriorly you have the subscapularis, the pectoralis major. Posteriorly you have the infraspinatus, teres minor. Superiorly you have the supraspinatus, the fibers of the deltoid, and inferior relations you have the pectoralis major and the long head of the tricep muscle. And don't forget to mention these two important structures, that is the axillary nerve and the posterior circumflex humeral artery. Students, coming to the blood supply of the shoulder joint. So as you know, any joint, it is supplied by branches of the artery which supplies the adjacent structures. So here, if you look at this, the subclavian artery continues as the axillary artery. This axillary artery is divided into three parts, 1, 2, 3. So from this third part, we have these two branches arising, anterior and the posterior circumflex humeral arteries. The anterior and posterior circumflex humeral arteries. Apart from that, you have this branch, the suprascapular artery. This is coming from the thyrocervical trunk. So here you can see the thyrocervical trunk. And from there, a large artery, that is the suprascapular artery, is coming and giving supply to the shoulder joint. Nerve supply, students. The shoulder joint, it is being supplied by the suprascapular nerve, the axillary nerve and the lateral pectoral nerve. So kindly remember this as it is very important. So factors providing stability to the shoulder joint. This we have already discussed. So in a brief way, I will just tell you the dynamic stabilizers are those which are moving along with the movement of the shoulder joint. So it includes the rotator cuff, the coracoclavicular arch, the tendon of the long head of biceps, and also the pericapsular muscles. What are pericapsular muscles? The muscles which are surrounding the shoulder joint. So you know what is that? The rotator cuff muscles. And what do you mean by static stabilizers? Static stabilizers, well, they remain in their position. So the glenoid labrum, the fibrous capsule, and the superior middle and the inferior glenohumeral ligaments. These ligaments we had discussed, which are present on the inner aspect of the fibrous capsule. What are the different movements that are possible? So since it is a which type of joint? It is a ball and socket variety of synovial joint. So it is going to provide huge range of movement or motion. The head of the humerus acts as the ball and socket is the glenoid cavity. So in this image you can see this type of movement of the shoulder joint, it is the flexion, whereas movement backwards it is the extension. Similarly, if we move the body shoulder away, the arm away, it is the abduction. If we bring the arm closer, it is adduction. Two other movements we had discussed in our general anatomy classes, the medial rotation and the external rotation or the lateral rotation. Internal rotation, external rotation. All right. And when we combine all these movements together, combination of all the movements will give rise to the movement known as circumduction. So please don't forget to mention this movement as you write the answer, that is the circumduction, where the proximal part is forming the tip of the cone, whereas the distal part is forming the base of a cone. So finally, moving to the last few slides, the applied anatomy. So anterior dislocation, it is the most common, occurs almost 97% cases, and it results due to trauma. And what is injured? The fibrous capsule, the glenoid labrum, it leads to are injured. And what it leads to? It leads to the damage to the axillary nerve. So students, what will happen if the axillary nerve is damaged? We know the axillary nerve, it is going to supply muscle, that is deltoid, also the skin overlying it. So paralysis of the muscle as well as loss of sensation over a small area over the deltoid. That is known as the regiment badge sign. Loss of sensation over a small area of skin over the shoulders, where usually the army officers used to wear their badges. Inferior dislocation, well, it is very uncommon. It is less than 1%. And what is happening here, the due to a sudden hyperabduction, when the shoulder joint is suddenly hyperabducted, this leads to the pushing of the humeral head against the acromion process, and this leads to the inferior dislocation. Posterior dislocation occurs in less than 3%, and this occurs when the humeral head it is forced posteriorly. When the humeral head it is forced posteriorly in case of internal rotation. So when the arm is abducted, internally rotated, and sudden posterior force is applied, it leads to the posterior dislocation of the shoulder joint. Now this is very important, students, the frozen shoulder. This is a condition generally seen in people above the age of 40s. In this, what happens? The fibrous capsule, it has layers. So layers of the fibrous capsule, they get adhered to each other. Hence, it is also known as the adhesive capsulitis. It is a very painful condition, and it generally restricts the abduction of the shoulder joint. And finally, moving to a deformity which is present from the birth. Such deformities which are present from birth are known as the congenital deformities. So this is known as the Sprengel's deformity, in which the scapula, as you can see, it is at a much higher level than the normal. So this is due to the failure of the scapula to migrate down from the cervical region. So that's all for this class. Hope you understood well. Thank you.